Hey guys, the audio is not going to be great for this, but I think it gets the point across. This is my conception of intensive care, and I could be wrong, but this is the way I think about it. And essentially it's the shit graph, or for impolite company, the stuff graph. And there's a lot of things we need to do acutely for a critically ill patient. And so when you have your resuscitation area, and it would be great if this stuff was done with a really sharp slope. Now, if this stuff is done with kind of crappy slope and never gets done, then the patient kind of dies, and that's bad. If this is done properly, then you get a nice sharp slope in the first couple hours to the point where the patient is now stabilized. And that's the resuscitation phase, and that ends once the patient's stabilized. And generally that is the same time that we stop adding shit to the patient. We stop adding all this stuff, and now we have the maintenance phase of critical care. Now, that first phase, that's resuscitation. That's what every good ED doc should be able to do. It's what every intensivist needs to be able to do. It's what every anesthesiologist that deals with really sick patients. It's what trauma surgeons, they all need to be resuscitationists. The maintenance phase, on the other hand, it's a different mindset. What you need to do there is you need to just keep the patient from getting iatrogenic complications and just keeping with tiny little perturbations, as opposed to, if you're not careful, if you're not incredibly obsessive compulsive, if you're not making sure everything that the patient needs is being done in a way that's safe to them, then the patient's going to have these horrible recurrences and need to go back to resuscitation and get even more stuff done before they get back to that maintenance phase. But a nice maintenance phase, all is well. And then perhaps the hardest part of intensive care is knowing when to start taking stuff off, when to start removing the central line, when to extubate the patient, when to actually start moving them down to lower levels of care, and then the patient goes out. And that's the ideal course. And the shorter you get this time, that's going to be the mark of a good intensivist. But resus is just that first phase, and that's what a resuscitationist needs to be good at. This stuff, well, that's what an intensive care doc needs to be good at in addition to the resus. So that's just my take on it. I don't know what you think.